Good afternoon, respected judges and everyone present. I am Dr. Rajneel Bhattacharjee, Registrar of Shilchar Medical College. Squamous cell carcinoma is a type of invasive malignant tumor which arises from the squamous cell layer of the epidermis. When it occurs in the ocular and periocular region, it can involve structures like conjunctiva, cornea, and eyelid. Squamous cell carcinoma presents as a range of progressively advancing malignancies from precursor actinic keratitis to in situ squamous cell carcinoma, invasive squamous cell carcinoma, and finally to metastatic squamous cell carcinomas. Squamous cell carcinoma commonly arises from the lid margin in elderly patients de novo or from existing lesions like actinic keratosis, Bowen's disease, radiation dermatosis, or immunosuppressive drugs. Histopathologic characteristics of squamous cell carcinoma depend on the degree of differentiation of the tumor. In well-differentiated squamous cell carcinoma, the cells are polygonal with abundant eosinophilic cytoplasm and prominent nuclei, dyskeratotic cells with characteristic keratin pearls and intercellular bridges. I present a 65-year-old female which presented to the ophthalmologic outpatient department with chief complaint of a growing mass on her left upper eyelid on the left eye for 6 years. On elaborate history taking from the patient, we found that the mass was initially the size of a pea but slowly increased to its current size over a period of 6 years. There was no history of associated pain or bleeding from the mass. There was difficulty in seeing from the left eye due to the mass obscuring her left eye. Ocular examination revealed a firm mass of size 3.5 into 3 centimeter into 2.5 centimeter involving left upper eyelid margin. It was non-tender and did not bleed on touch. However, brown and black hemorrhagic areas were seen on its outer surface. She had pseudophakia in her right eye and phakia in her left eye with visual acuity 612 and 618 in right and left eye respectively. Fundus examination was normal in both the retina. On general examination, there was no lymphadenopathy or organomegaly was noted. Her systemic examinations results were within normal values and no chronic illness. The differential diagnosis we consider were squamous cell carcinoma, sebaceous cell carcinoma, pyogenic granuloma were made. Routine blood investigations like blood sugar, virology, bleeding, ECG, chest X-ray, all other routine were normal. The excision was done with wide margin at the base under local anesthesia and the defect was closed directly. Post-operatively, there was some edema over the wound site and she was prescribed topical and systemic medications. From post-operative day 1, the patient got relief and could directly see. Histopathologic examination of the specimen showed well-differentiated squamous cell carcinoma. The margins were free from tumor. Follow-up was done at regular intervals and she improved. After 1 week, we can see she has drastically improved. So, the squamous cell carcinoma can be, the presentation can be varied, leading to difficulty in diagnosis clinically. The histopathological examination is mostly required for the correct diagnosis. A lot of studies have shown that clinical diagnosis can be inaccurate preoperatively. In one such study, squamous cell carcinoma of the skin diagnosed clinically was confirmed in just 51% of cases only. The treatment of eyelid tumors is varied and a lot of choices are present. The choice to follow is depending on the pathological process present. It includes surgical excision, cryotherapy, radiotherapy, electrofulguration, topical application of 5-FU, intranasal bleomycin, corticosteroid, or different other techniques depending on the position and mainly on the size of the lesion. Interferon infiltration has also been used intralesional along with laser surgery and photodynamic therapy. The advanced and extensive squamous cell carcinoma also requires systemic neoadjuvant chemotherapy or palliative chemotherapy. Although there have been very few studies to compare the efficacy of this treatment, the surgery and radiotherapy seem to be the methods most effective, and the surgical treatment is the procedure with the lowest rate of recurrences. The various techniques used in the treatment of eyelid tumors can lead to good cosmetic and functional result. Depending on the location, size, and severity of the tumor, the results may range from a small scar to permanent changes in the structure of the eyeball. In our case, the large size of the tumor and its unique way of presentation on the upper eyelid was a rare scene. the mass was hanging down from the upper eyelid and completely obstructing the vision in the left eye. So it was our aim to surgically excise the whole tumor and give the patient some relief so that she can live her rest of her life disease-free. The case is show large squamous cell carcinoma, which is not very commonly seen in recent published literature. The patient presented to us with a large sized tumor after having it for a long term due to ignorance and lack of awareness of cancerous growth in the body. Early diagnosis and treatment reduce the morbidity and mortality of the patient, and the most important is to consider the possibility of a cancerous lesion in addition to benign conditions which we might miss. In a case of a collagen also may turn out to be squamous cell carcinoma, so we should always look for the possibility of a cancerous lesion even if we think it to be a benign lesion. Thank you.
How many of you routinely send collagen also to histopathological examination? Yeah. Recurrent cases you are sending. But the age group also important. Above 50 or 55 years age, even without recurrence also, first time also, better to send the specimen for HPE because thereby we can avoid all this. What do you say?
Ma'am, yeah, I mean, usually in the recurrent cases, that's what I do in my practice, not in regular, and especially if it is an elderly age group. If it's a young patient, obviously not, but if it's an elderly age group. But there are situations where I have seen granulomas like chalazion, where it has turned out to be a TB granuloma also. So these things can also be ruled out in a very diffuse granuloma, which is slightly abnormally looking and not typically like a chalazion. Now,
the patient stay with the chalazion for years before getting it treated. So that long history, that does not need recurrences even, because the patient may be staying with the chalazion for 2 to 3 years like that. They stay without any treatment anyway. And when they present to us, and maybe by chance we suspect that it is maybe cancerous, we send for histology and it might turn up. We have found a lot of cases like that actually.
Right. Now, another thing that I really want to highlight here in your case is when we talk about squamous cell carcinoma, you said chalazion, sebaceous gland carcinoma. So what I want you to understand is there are cancers which arise from the anterior lamella. There are cancers of the eyelid which arise from the posterior lamella. Okay. In your case, it is purely anterior lamella. It is skin. All right. Yeah. So the cancers, which is rapidly growing, huge tumor, that you have to think about as a differential diagnosis is squamous cell carcinoma, keratoacanthoma, and basal cell carcinoma. All right. Now, when you talk about chalazion, it arises from posterior lamella. So the posterior lamella malignancy is usually sebaceous gland carcinoma. So when you talk about chalazion, it never is equal to a squamous cell carcinoma. All right? Yeah. When you talk about chalazion, the differential diagnosis of a malignant lethal eyelid tumor is sebaceous gland carcinoma. Yeah. So something hanging from the skin which is so large as in your case, which is obviously not too common, is squamous cell carcinoma or basal cell carcinoma or keratoacanthoma in our practice that we keep in mind, and it's all for the students, you know. So depending upon the location, whether it's anterior lamella or posterior lamella, you can actually have a differential diagnosis in your hand. Yeah, thank you.
Which is a better term, sebaceous gland carcinoma or meibomian gland carcinoma, or both are same?
It arises from the meibomian glands, but it can also arise from Zeiss glands, it can arise from caruncula. So a universal term would be a sebaceous gland carcinoma, but yeah, it is a sebaceous gland. Meibomian gland is in the tarsus, Zeiss gland is in the tarsal margin, caruncle has sebaceous glands. So the generalized term is sebaceous gland carcinoma. Yeah, right.